Hello, everyone. Welcome to our final concurrent session of the conference. I'd like to welcome Wa Apple, Robin Fleming, and Serena Barrett, who will present on community engagement in economic social determinants of health, addressing unequal access, treatment, and behavioral health. Dr. Wa Apple's work centers on improving the mental health of community members by examining access, prevention, and disparities. She teaches UW public health and nursing students, leads the behavioral health team at UW Bothell School of Nursing, and is the principal investigator of research projects focusing on improving and broadening understanding of the mental health of underserved populations during and after the COVID-19 pandemic. Previously, she was the National Institute of Mental Health postdoctoral fellow and researching mental health disparities among Asian Americans and Latinos. Dr. Robin Fleming teaches health policy and public health at UW Bothell, where she is also co-director of the K-12 behavioral health program. Dr. Fleming's extensive experience spans school health education and policy at various levels. As a Robert Wood Johnson Foundation Health Policy Fellow, she worked with U.S. Senator Tammy Baldwin and the Congressional Research Service. Before her fellowship, she managed school nursing services across Washington State's 295 school districts. Dr. Fleming's research, published widely in peer-reviewed journals, explores the link between student health and academic performance. Serena Barrett is a communications specialist at the Latino Educational Training Institute in Linwood, Washington. She earned a BA in Health Studies from UW Bothell and joined LETI in 2022 as a caseworker for the Emergency Rent Assistance Program. She currently coordinates the Latino Leadership Initiative, including leading a research project on behavioral health in underserved populations, and manages outreach for the Community-Driven Outreach Project, including engaging Latino communities across Washington State on health and behavioral health issues. Wa, Robin, and Serena, please take the stage.
Yes, thank you very much for that introduction, and thank you all for joining us today. First, we would love to get an idea of who we have here in the audience. So I will be asking 4 questions, and I would love if you could use the reactions button located at the bottom of your screen to help us see the answers to those questions. So please click the clapping hands icon if you work in the healthcare field. Oh, perfect. Thank you. And please click the heart icon if you work for a school or a college. Great, thank you. And please click the thumbs up icon if you work directly with youth or if you have children. Great, thank you. And finally, please use the sunglass icon if you have experienced or seen an increased need in mental health in schools. Perfect. Thank you all for your participation. It looks like we have a wide variety of folks here today, which is great. I did notice a lot of you were in the healthcare field and work directly with youth or have children, so that is great for us to know. So today we will be splitting our presentation into 3 specific sections. The first will be economic inequality and its effects on mental health. Next, we will touch on integrative care and behavioral health. And finally, we will be speaking on addressing mental health in school and community settings. And with that being said, I would like to pass it on to Dr. Robin Fleming.
Good morning, everyone. Thank you so much for joining us today. And I want to thank Harborview for putting on this critically important conference and showcasing this important topic that we all have a stake in and that we all, I believe, who are here today are committed to improving. So as we get started talking about economic inequality and its effects on mental health, in order to understand how racial inequalities and economic circumstances affect mental health, we first must understand how inequalities are measured. So the four ways that I'm going to discuss briefly today are the Gini coefficient, excess medical care costs and how those are distributed, lost labor market productivity costs us a lot, and of course, premature deaths. Next slide, please. So this is a depiction of the Gini coefficient. So what the Gini coefficient does is it's a summary of inequality in the distribution of household income, where the number 1 represents complete inequality and the number 0, I guess that's not a number, 0 represents perfect equality. And so it's helpful at conducting comparative analyses in particular of ways that economic inequality, particularly over time, compares estimates of health and health risks among entire populations or specific groups. So as is illustrated in this slide, you can see that as the Gini coefficient inches up toward 1, physiological dysregulation in the population concurrently increases. So this is about health inequalities, right? And so we know that mental and physical health are intricately connected. So our bodies know when our minds are not well, and they respond in kind with stress, heart disease, high blood pressure, increased incidences of cancer, diabetes, etc. Next slide, please. So we look at the 3 other topics. So the Gini coefficient was one way of measuring. The other 3 measurements are excess premature deaths, lost labor market productivity, and excess medical care costs. And you can see that on the left side of the slide, this is the total burden borne by racial and ethnic minority groups economically. So you can see, for example, that African Americans bear the most. So that's total, but on the right-hand side is sort of the aggregate of how these different measurements, how different populations are represented in these measurements. So African Americans have by far excess premature deaths. However, I would like to point out that American Indian, Alaska Natives, as well as Native Hawaiians, have a disproportionate share compared to their population. So they actually experience it more. It's just that African Americans are a more populous population. So this is incredibly expensive, and this total burden, just to put it in perspective, of racial and ethnic health disparities was $451 billion and almost $1,400 per person, which in 2018 was about 2% of the US gross domestic product. That is comparable to the annual growth rate of the economy in 2018. These are massive numbers. Next slide, please. In addition to measuring it by economic levels, we also measure by educational levels, because we know that education affects health. And we know that the higher educated the population, the healthier they are. That's been borne out by research over and over again. So we look here to see that who carries the biggest burden by the level of education. Those who have had college bear the least burden. Those who have had high school GED seem to bear the most, and those with less than high school, 26%. And that seems a little counterintuitive, but it's important to note that the disproportionate share was borne by adults with less than a high school diploma, and they were only 9% of the population, but bore 26% of the burden. So next slide, please. Now, if we look across the country and we compare states to the economic burden borne by racial and ethnic minority groups, we can see that Washington State, and this is a result of the policies we have here and the access to healthcare we have here, it's better comparatively to some southern states in particular. So about up to $800 is borne by the states. In the lightest category there. The darkest are the states where people by ethnicity bear the greatest burden per person. And then we're going to look at the next slide, which shows us how this is borne by educational levels. So we don't do as well in Washington State at that. And I could give a whole nother presentation on perhaps why that is, but it's investments in birth to 5 in overall, and we will get to that part of the presentation a little bit later. Next slide, please. So the effects of inequality. Now that we know how it's measured and how it impacts our populations, let's look at how it affects us more on an individual and community level. Next slide, please. So the individual and community levels are very well linked. Every individual is part of a community, but it's mostly mediated. Mental health is mediated by psychological and physiologic stress. So at the community level, what happens? Somebody else has an unfair advantage. Somebody has a better house or a better car or goes to a better school or has, a better yard or whatever, you measure that by. It causes people to feel left out. It causes people to feel anxiety. It causes them to want to withdraw and not participate and engage. And it causes an erosion of our social trust, which is so important in building up our communities and improving the health of our communities. The other very important aspect is that childhood inequality is linked with poorer health in adulthood. And this can be looked at from a number of different measures, from how many words a child learns in their first year of life to where they're at that first day they step into a school and enter kindergarten. Have they had the resources they need to develop into healthy, thriving children by the age of 5? We know, for example, I'm writing a paper right now on the poverty to prison pipeline and ways at which nurses intervene at critical developmental stages to interrupt that pipeline. The most important stage is that birth to 5 stage. And the nurse family partnership, Head Start, early Head Start, these programs have shown over decades that they are critical to keeping students from entering the prison pipeline and to keeping students better able to compete on an educational level. And that's what we need. Our health and our education are inextricably linked. So childhood inequality has to be stopped, and we can do it, and we know how. Next slide, please. And I will turn it over to Dr. Apple.
Okay, I was on mute. I apologize. I'm Hua Apple, and I will talk on the next few slides here. The first one is on community engagement and partnership. So first, research shows there is a significant association between social relationships and mental health outcomes at the individual and also at the population levels. There is a positive relationship between that sense of community and mental health. Social capital is one of the several related phenomena that shows there is a positive association between one's general health and mental well-being. So what is social capital? That's that social relationship between individuals that function as resources that affect different dimensions of their well-being. What is community? It's that feeling that members have a sense of belonging, feeling that members matter to one another and to the group, and a shared faith that members' needs will be met through their commitment to be together. So there is a statistically significant association between the sense of community and symptoms of mental illness, such as depression, anxiety, and stress. Behavioral health. So that term is an umbrella term that includes both mental health and substance use conditions, or substance use and misuse or abuse. So the stressors, crises, stress-related physical symptoms, and health behaviors. So behavioral health conditions often affect mental or medical illnesses. Next, we're looking at the integrative behavioral health services. So the availability and the integration of behavioral health services into communities promote accessibility, promotes acceptability, and also the affordability of health services. Also, the integration of behavioral health services promote adherence to treatment. You want your clients to adhere to the treatment plan that's devised by both provider and the client, and also increase that likelihood of positive clinical outcome. Next slide, please. So this slide is about integrated behavioral health care. So what is that? That is your one-stop health services for all your clients or patients' needs. This is behavioral illness is usually co-occurring with physical illness. So integrated behavioral health blends healthcare in one setting for medical conditions and related behavioral health factors that affect one's health and well-being. So there's a few different terms, and it means the same thing for integrated behavioral health care. It's part of whole person care. You hear that as behavioral health integration. So this is that rapidly emerging shift in the practice of high quality healthcare. It's also called integrated care, collaborative care, primary behavioral health care, all mean the same thing. So it really doesn't matter what one calls it. The goal is we all have a common goal, which is better healthcare for the whole person. So providers practicing integrated behavioral health care recognize that both medical and behavioral health factors are important parts of a person's overall health. So that coordination is very important. The collaborative approach with providers, discussion with clinicians in the same office, the interdisciplinary approach on how to best use evidence-based care so patients can benefit from providers working together on how to best serve your clients or patients. Great. Next slide, please. So next we have, I am going to talk about a few things here relating to mental health disparities. The first is SDOH, or social determinants of health. We all have heard about it. It's the CDC defines that as the conditions in which people live, learn, work, and play. It's determined by the distribution of money, power, resources that affect a wide range of health and quality of life risks and outcomes. Economic disparities, as Dr. Fleming previously mentioned, disproportionately affect Black, Indigenous, people of color, or BIPOC within zones marked by substandard health promotion and excessive health risks. So these compounding natures of adverse SDOH, social determinants of health, like housing, instability, food insecurity, poor healthcare access, hazardous exposures to various chemicals depending where they live geographically. So these have serious health implications. So the health disparities are the profound downstream effect of social economic disadvantages that affect the BIPOC population. Next, please. Next is implicit bias. That is the unconscious attitudes, positive or negative, towards a person, a group, or an idea. It leads to differential treatment based on perceived race. Implicit bias further restricts quality health care as a separate factor above and beyond the inequity of structural racism. Emergency department, RED data, shows that Blacks versus white patients have longer treatment wait times, have longer lengths of stay, and lower triage acuity levels. Also, Black ED patients have at least a 10% lower likelihood of being admitted and almost 1.5 times higher odds of hospital deaths comparing with white patients. And research also suggests that physicians' own implicit racial biases may contribute to disparities in the healthcare quality and delivery. Next, please. Mental health disparities. In the US, about 1 in 5 adults live with a mental illness. And it's also estimated nearly 50% of the population will have mental illness over the course of their lifetime. So that is a huge number. Adults identify concerns such as cost, scheduling difficulties as the key barriers to mental health care. We have research shows Hispanics, Blacks, Asian adults disproportionately report additional challenges besides the barriers just mentioned, like finding a provider that can understand their background and experiences, especially lived experiences, and lack of information, stigma, embarrassment. So that all falls under the disparities in mental health. Among those who thought they needed mental health care, but they did not try to find a provider, research shows Hispanic adults are more likely than white adults to say the main reason was they didn't know how to find a provider. 24% shows that. Or they're afraid or embarrassed to seek care, about 30% compared with white. Across racial and ethnic groups, about half of all adults, it's about 53%, who report that they received mental health services, say they were very or extremely helpful. So it's that difficult step to get them to get help. And then they will find it much more helpful than, of course, not seeking help. Next, please. The last part here is on the lack of awareness of the 988 mental health hotline. So as I previously mentioned, about 20% of adults live with a mental illness, and nearly 50% of the population will have mental illness over the course of their lifetime. So this 988 mental health hotline, unfortunately, remains low, the usage overall. As of summer of last year, data shows summer of 2023, only about 1 in 5 adults say they've heard of it, of the 988 hotline. Blacks, 16% have heard of it, Hispanics, 11%, Asians, 13%. So they're less likely to have heard about this compared with white adults of the 988 hotline. About 21% of whites have heard of it. So this is not good statistics, considering at the same time, we have 21% of adults say they themselves or a family member has ever experienced a severe mental health crisis that resulted in serious consequences like homelessness, hospitalization, incarceration, self-harm, suicide, and then among young adults, which are the 18 to 29, that rises to 39%. So it's very disparaging statistics, I believe. And that concludes that section. Thank you, Serena.
Hi. This is Robin's section. Thank you, Wa, for that. So talking about the incidence and the prevalence of mental health conditions in the adult population, we're going to switch back to talking more about kids. I'm really glad it's like all of you are in the health field, which is not surprising, but many of you work with children. And focus on mental health. So I think hopefully this will be of interest to you. And I would love to hear your thoughts as we discuss this later on. But as is no surprise to anyone, there was a surge in the mental health needs in K-12 settings post-COVID. And that was mostly as a result of kids that were affected very deeply by COVID and disproportionately by compared to white youth, ethnic, racial minority youth were disproportionately affected by COVID-related health disparities and experienced elevated worry and stress. And so, you know, it wasn't good before COVID. It wasn't good. I was a school nurse. I worked in Seattle for 13 years. And I would say that 25% of my students had a diagnosable mental health condition, in addition to many physical health conditions that were present in the building, and many of them life-threatening. But mental health, as I said earlier, is very connected to our physical health. You get a lot of kids with tummy aches, a lot of kids with headaches, and you'd see them over and over and over. And over time, it became clear that their tummy was speaking about something in their life that was bothering them. So getting to the upstream cause of what was happening. But I like to look at people from a strengths-based perspective. And I think that we need to do that instead of saying what you need and what's wrong with you. What's right with you? What's going on that we can use as a strength to improve your health? And I will say that our children in general are very resilient and they're very open. And they especially have promoted positive adaptation and psychosocial well-being despite all of these barriers that they faced related to COVID. But the numbers don't lie. 69% of schools reported an increase in the number of mental health concerns in their students. And as I said, ethnic, racial minority youth experience disproportionate COVID-related health disparities. So let's see where our kids are getting their services, their mental health services. Next slide, please. So what's interesting, what the research literature tells us is about 25% of students have, and I think that number has risen. If you look at the Healthy Youth Survey in Washington State, which I would recommend that all of you do, because our youth are feeling very disconnected and very alone in navigating the challenges, whether that be food insecurity, whether that be connection at school. School is so important. So most students, unsurprisingly, receive most of their mental health services at school. We do know that about 80% of mental health goes untreated, which is why you see that there's not very many kids being treated. But most kids get treated at school. So that's 7.28% compared to very closely tied with sort of outpatient at 7.2%. And I believe, especially for our low-income students, our ethnic minority students who don't have options for travel, who don't have a copay they can pay. And we know there are still very significant disparities between reimbursements for physical health and mental health, that you know, parity was in the law of the Affordable Care Act, and that is still not in practice happening to the extent that the law dictates. Kids are also getting mental health services through inpatient care. So that's mostly crisis related, through the child welfare system. So our foster children, and then unfortunately in the juvenile justice system where they don't belong. So next slide, please. Because they are getting the majority of their mental health services at school, let's find out what are the characteristics of students that receive diagnostic mental health services, not treatment, but diagnostic. So we know that more than half are in secondary schools in urban environments, and more than half are students of color, and more than half are low-income students. Next slide, please. In terms of treatment, excuse me, slightly higher in middle schools than in high schools, but pretty much even. The majority of treatment services are offered in urban areas with high numbers of students, like greater than 1,000. And the percentage of schools providing treatment services didn't vary measurably by percentage of students of color, but it did vary by income level. So the lower income level, the higher the treatment level. Because we know that income inequality makes us sick, and it makes us mentally, it predisposes us to having more mental health challenges, right? Next slide, please. So what I want to talk about here for a little bit is the difference between what school nurses provide and what school-based health centers provide. I was a school nurse for many years and then oversaw school health services throughout our state for 3 years. And I've worked as a school nurse in schools with school-based health centers and schools without school-based health centers. And I can tell you that having a school-based health center is much more preferable. So school nurses, I'm just going to use kind of get you to think about something. So if we have a hospital in a community, do we still need a public health system? I guess click an emoji or something. Yeah, I'm seeing a lot of thumbs up. So public health is the prevention arm. And you know what my son once said to me when he was little, and I would drag him around to all these meetings, you know, school meetings, and I worked with immigrants a lot and all these meetings. And he said, Mom, I think what public health is and what school nurses do is what you do as a mom. If you just quit doing it, our house would be chaos. We wouldn't get rides anywhere. We wouldn't get fed. Laundry would be piling up. The dogs wouldn't be fed, you know. And so that's what public health is. You don't see what it's doing unless something goes wrong. But people are furiously working behind the scenes to ensure that things stay safe and healthy and don't go wrong. That's what school nurses do. They have access to the entire population of a school. School-based health centers have access to students who are enrolled in the school-based health center, and that requires parental consent. And as many of you probably won't be surprised by, many parents do not provide consent because they are worried that their child will be getting services such as reproductive health services or mental health services, and the parent doesn't want to be kept out of that loop. They don't want these services to be confidential because they want to know what's going on with their kid. What they don't realize, many of them, is that students have a right to confidential reproductive and mental health services at the age of 13 in Washington state. So they could come to you, the school nurse, if the parent doesn't allow them to be enrolled, which is what many of them did. And I would refer them to other agencies. Now, many of the agencies that we collaborated with, I worked at Franklin High School for 3 years. Many of the agencies we collaborated with were so amazing, and they would come to the school and they would provide mental health counseling for students where the students were. So the students didn't have to go somewhere after school that they couldn't get to. They were right where they were. That's the way to do it. Most students are getting their mental health services at school, and those services need to be accessible. And that can be done by school-based health centers and by having community partners who work with school nurses and school-based health centers to make arrangements to treat students. The other thing that school nurses are responsible for is medication management and administration for all students within the school building. School-based health centers, again, see the students who are enrolled. Typically, that's about a quarter of the student population. So the school nurse is seeing 75% more students, and the school nurse has an open door. There's no appointment. You just come if you need something. And you do have to have an appointment. A school-based health center is a clinic, and so you do need to have appointments. They do prescribe. Most of these school-based health centers are run by amazing nurse practitioners who are leading these centers, not only in Seattle and in Washington State, but around the country. And they are providing excellent care and keeping students from falling through the cracks and providing them critical access. So they are very important as partners with school nurses. The other thing that school nurses do are provide all the health screenings for the entire student population as required by law. So in Washington State, there are vision and hearing screening requirements. I know that the levy that supports funding of school-based health centers and some funding for school nurses, they did when I was working as a school nurse have a requirement in order to get the funding for school nurses that we had to do screening for mental health services for students. So I would be screening a lot of students for this, which was helpful. What wasn't helpful is I found out that the need for mental health services far exceeded the access and the amount of providers. And at some point, this became unethical to me to say to students, I see that you are wanting treatment for mental health services, but I have no one to refer you to. We're full. And so we have to find ways to make those services accessible and increase our workforce in this area. The other thing school nurses are responsible for is making sure that all students are vaccinated. Washington State has a law that if you are not vaccinated for certain illnesses, you can't attend school. And so, I mean, at the beginning of the school year, there's a lot of students out of compliance. So what do you do? Say you can't come to school? Nobody wants that. We all want our kids in school. So we would have conditional status where we would talk to the parents. We would get them, signed up. Hopefully they would be signed up in the school-based health centers, which many of them provide vaccines, which are critical at keeping students at school. Some vaccines they don't provide because the way the vaccines have to be stored sometimes isn't consistent with the kind of equipment they have or the ability they have to do that. The other thing that school nurses do is provide classroom health education on a variety of topics, from oral health care, dental health, reproductive health care, germs, communicable disease prevention. So they go out in the classrooms and they really get to know students, and they're really part of the school. They also sit on student intervention teams. So every time a student is perceived to have an issue that may be interfering with their ability to engage or succeed academically, they are brought to a council, so to speak. That includes parents, students, if necessary, all teachers, school psychologists, school nurses, that talk about ways to identify that student's strengths and how we can mobilize those strengths to help the student, and what we as a community, as a school, can do to support that student in realizing these strengths and using them to succeed academically and socially. within schools. They contribute to, school nurses contribute to and lead on overall school building, environmental health and safety. And I do know that the Washington State Board of Health right now is reviewing school environmental RCWs. They are going to be, or WACs, they're going to be updating those. And so they are in the process of creating draft right now. And my students are actually working with the Board of Health on that. So our environment has to be safe. We have to have clean air. We have to have clean water. We have to have, stations in our chem labs and playground safety and pest safety and communicable disease safety. I hate to say it, safety in terms of shooters in the building and other kinds of dangers. Earthquake safety, how to get our students out who are on ventilators or who are in wheelchairs. How do we get them safely out of the building? What do we do in a lockdown situation? These are all environmental safety issues that affect our students' mental health as well as their physical health. School nurses are also responsible for the creation of healthcare plans for students with potentially life-threatening health conditions, which have been increasing over the years. We are seeing more students with diabetes, severe diabetes in some cases. We see students with seizure disorders. I've treated students with sickle cell anemia, with cancer, with anaphylactic allergies, with brain shunts, with trachs. So we have complex needs in our students, and also students with severe mental health disorders, such as oppositional defiant disorder, OCD, anxiety, social anxiety, autism. The list goes on, right? And we need to take care of all of these students. So what I guess my point in looking at school nurses and school-based health centers is a school-based health center alone is not. Also, school-based health centers are under HIPAA, right? School nurses fall under both. They work for education systems. School-based health centers work for health systems. So their charge is different and their governmental oversight and rules are different. So I have the responsibility as a school nurse to protect educational records, and anything that you put into your health system as a school nurse is subject to FERPA as well as HIPAA. So for some very, very sensitive students being abused, students who have reported rape, students who have reported very sensitive information, their parents have access to that information under FERPA. Just a privacy issue that I think is important to relay here. Okay, next slide, please. So this is really our recommendation slide. So this is, where do we go from here? Okay, one of the things that I want to share with you is that Washington State is the only state in the nation, and this is so excellent, that has what's called a school nurse corps. And I managed that program at our state education agency for 3 years. The school nurse corps is an infrastructure for a healthcare system. School nurses are a national healthcare system. They catch students in the cracks that are going down. They provide them access to healthcare. They get families signed up for healthcare. They provide support. I've had students with cleft palates who had no money get free operations. They can do all these things. They are plugged into all the providers around them, the resources, vision providers, getting students free glasses, getting students free medical devices to help them engage with and succeed at school. So we definitely need to have an increase in school nurses. As the former co-director of the behavioral health program at University of Washington, Bothell, we provided modules for teachers and school staff to educate them about mental health issues in students. I guess that my thought on that is that teachers and school staff need to have a fundamental understanding of this, but they don't need and can't be mental health providers. That's not their job. We need them to teach. We need our students to be graduating from schools, able to write, able to do math, able to do the things that are required of them to have meaningful, purposeful lives of work and contribution and purpose. And they can't do that if they can't read or write. And we are seeing too much of that. So teachers need to focus on teaching, and we need to have more healthcare providers in our buildings. And those healthcare providers need to be representative of the students who are attending our schools. We need more people of color. We need more bilingual providers. And so we need to increase this. And what the Washington State Legislature did with the School Nurse Corps program, the reason it was started in the first place was in 1997, the legislature did a survey to find out what access students in rural areas had to school nurses. And the answer was not much, if any. And so there were issues with that in terms of federal law and federal funding. And so they started the School Nurse Corps, and they funded it with $5 million a year. And what that money did was create a Nurse Corps administrator in each of our state's 9 educational service districts, with a lead administrator at the state education agency, dole that money out to the Nurse Corps administrators in the 9 districts. They use that money to hire nurses, to make sure those nurses, their licenses followed the degree of the law, to help administrators understand who they could hire and who they couldn't, to do surveys of the school to find out who the students were, what the level of need was, and to figure out the FTE that the nurses should be in the buildings. And so it was very, very important. And they collected data on how many health conditions, on what trends they are seeing in different regions of the state. I mean, this is an incredible system. But what happened is, people don't know what school nurses do. They think they're putting on Band-Aids and cleaning up vomit. And yeah, there is some of that, okay? But they are public health sentinels. They are doing so much behind the scenes work that those moms do that if they didn't do, your house would be a mess. Okay. And so after COVID, the legislature woke up and said, oh, we need to prevent this. So they more than doubled since 1997. So how many years has that been? 27 years or something like that. There was no increase. Health needs were going up. School nurse FTE was going down. It was getting bad. So they did increase the funding, not to the point where it has kept up with inflation, but still it's better than it was. But we can't let up. We can't let up on this. We need to continue as healthcare providers, as people who care about our children and our children's health, to continue to push the legislature to provide the funding that's necessary to ensure we have a workforce, to ensure we have mental health workforce, to make sure we're providing these services in schools, because this is where students are getting their help. We need to make sure, so school nurse presence in schools, mental health professionals and SBHCs. Other thing that I have done research on, and that is so critical, is school culture. We need to have we all have bad days, right? And sometimes I'm not the nicest person I know I can be because I'm stressed on a certain day, or something bad happened at home or with my kid or whatever. But we as a school, as any kind of entity, need to deliberately create cultures of caring and connectedness. Whether you work at Harborview, whether you work at Franklin High School, whether you work at International Health Services, we are there to support each other, to help each other, to raise up our children. And so it has to be very intentional to create these cultures. And that definitely needs to happen in schools. And the research bears that out. We need to build capacity in our systems that impact children. We need to build capacity in our schools, our community centers, our housing, our food security, environmental safety. And as Wa referred to earlier, this is done through coordination, communication, collaboration. We can't be in our silos. Schools need to be working with transportation, with EMT, with housing, with food security, with mental health, with physical health. We need to be connected and all hearing each other, because health is in every entity, every single one. School need to partnerships with local mental health providers. That's part of it. There's also telehealth services. I think there's definitely a place for that, given the fact that we do not have enough providers right now. And that is a way that students can get that. We do need to be sure, however, that students in our rural areas have access to broadband and have access to the internet. Not everyone, shockingly, has that. And they cannot participate in life without it. So we need to make sure that that is happening all over our state. And as I mentioned, we need to increase our behavioral health workforce diversity. I know that the Washington Center for Nursing is working on this. They have a program right now where they're going into schools, working with teens, and trying to increase interest in the nursing profession and making sure that students of color are represented proportionally in that workforce. And then civic engagement. How can I talk about this without mentioning how important it is to have our voice heard and our voices and our visions reflected in the people we elect? I mean, this is so fundamental. And so I hope that you all are registered to vote. I make my students register. There's an organization called Vote ER, which is nonpartisan, provides badges. I know that some of my students who have worked at Harborview have used this badge as a way to register people to vote as part of our standard health assessment. We ask people, how much do you drink? How much do you smoke? Do you wear a seatbelt? Are you registered to vote? I don't care who you vote for. I care that you're registered, and I care that your voice is representing you. So, and this is not new. This has happened in health systems, and it's perfectly legal. It's a way to ensure that our collective voices are being heard and that our health needs are being heard. So, so that is sort of the end of our recommendation section. And if we go on to the next slide, I just want to thank you all so much for being here today, for sharing this with us, and want to just open it up to questions or comments.
That was fantastic. Thank you so much. I think we've got time for just a couple questions.
I talked too much. Sorry.
No, it was fantastic. Absolutely fantastic. I love social determinants of health and all of those pieces. But this question, can you share examples of successful community-led initiatives that have addressed behavioral health disparities through economic empowerment?
Wow.
Right?
Wa, would you like to take that one, Dr. Apple?
Sure. Actually, Leti, I can think of right off the bat, the Latino Educational and Training Institute, where Serena is from. They have been around for over 20 years, and they are helping the Latino community, especially in Snohomish County. Not just behavioral health. I think it's emerging. The initial focus was to provide education and empowerment for the Latino community. And then they branched out to helping find jobs and training and working as promotores, community health workers. Related to that is the little shameless plug here for UW School of Medicine. They have a BHSS program that stands for Behavioral Health Support Specialist. It's a bachelor's level program to help train workers to work in their own community, helping clients with behavioral health issues. So that just started a year or so ago, and there's ramping up. I believe there's 7 universities participating. And that's something, because when you go in and see a many of these folks, especially without insurance, it's at the community level, right? You don't go to a clinic if you don't have health insurance. So that bachelor's level is very important. The frontline workers who recognizes the behavioral health signs, symptoms, and where to make referrals to.
And I'll add something to that. So El Centro de la Raza also is, I wouldn't say it's an initiative, but it's an agency that I think started up in the 70s, and it connects, it's El Centro de la Raza stands for bringing all races together. They have daycare, they have food programs, they address all of these needs, and they are so critical to our community. So there's another one.
Thank you so much to our fantastic speakers. And now we will have a 5-minute break to